Please join me in welcoming our speakers tonight, Connie Steed and Paulina Rodriguez. Connie.
Thank you, Celeste. Thank you very much for a lovely introduction for Paulina and I. Paulina and I welcome you to this dinner, and we hope that you will enjoy what we're going to talk about tonight, which is bringing evidence-based strategies to the bedside. And we're going to focus a little bit on implementing and sustaining change, because that's an area of opportunity for us. And so we're going to talk about it. I don't get to get in the detail I like to. I teach a day-long or two seminar on change, but I'll be able to give you some key important things that we need to understand as IPs. And then you will see what Pauline tells you about. She gives you an example. So today we're going to identify the essential role of bathing with CHG and evidence-based bundle strategies to prevent HAIs. And we're going to understand more about the role of infection preventionists as change agents. And lastly, we're going to describe the impact of strategic horizontal approaches and ongoing compliance monitoring on sustainability, because that's a key word. We should never implement anything unless our plan is to sustain it. And that's an opportunity for us. So I'll start out talking a little bit about the evidence related to CHG bathing, followed by implementation and some thoughts on change and sustainability. As I indicated, Paulina is going to come up and give her story about getting quality improvement accomplished and her being a change agent within her organization. And then I will close with some key takeaways, and hopefully we'll have times for Q&A, but Paulina and I will be down here in the front if any of you have questions and we're not able to answer them. So these are my disclosures as a consultant at the present time. And now we're going to start with evidence. Now, all of us in this room, those of you that are seasoned infection preventionists, much as myself, know that there is a lot in the literature about CHG bathing. It could take me forever to go over all of it, so that's not my intent today. My intent is to quickly review the guidelines, which are evidence-based, and then follow up with 3 studies that I feel are interesting and may give us a little bit of a broader understanding of how CHG use as far as bathing is changing. So specific to the CDC and then the SHEA IDSA APIC compendium on CHG bathing, I specify the guidelines by location. In the ICU, the recommendation is universal decolonization for anyone more than 2 months of age. In the non-ICU, they recommend a targeted approach with patients with central lines and midline catheters. In the neonatal ICU, CDC published some new guidelines on NICU infection control last year. I hope you saw them. If you didn't, they are really important guidelines. And in that guide set, they did make a recommendation that to consider CHG bathing with neonates with CVCs, but the healthcare team needs to weigh the risks and the benefit to the neonates in the neonates condition, which is a big step. That's not been said before. And then in the preoperative area, again, a lot of research is done, but the best agent for preoperative bathing is still an unresolved issue. Basically, their recommendation is to use either non-antimicrobial or antimicrobial agents for preoperative bathing. But all of us in this room know that CHG bathing is widely used for this purpose. So the first study I want to go over with you is one that was done and published in AACN and by some critical care nurses. And it was to look at CHG programs to reduce HAIs in the ICU and non-critical care settings. And so their objective was to gauge the impact of routine 4% CHG bathing on HAIs in a med-surg ICU and a post-operative telemetry unit, which they deem a non-critical care location. In both of these units, they had a horizontal approach to skin decolonization. They also discussed in this article a little bit about the framework for a hospital-wide pre-surgical CHG bathing program. So their key method was to standardize the bathing protocol for 4% CHG, including time studies. People want to know, how long does it take a bath? to give a bath, not take a bath, to give a bath to a patient. And also did some monitoring of compliance, which was really important, and also monitored healthcare-associated infections to see what the impact was of CHG bathing on HAIs. Now, their implementation was a little unique in that they started in the med-surg ICU in January 10th, and they did not implement in the postoperative telemetry unit until February of 2014. And the reason they did it is they wanted to see its impact on non-critical care locations. Quickly, the results were the 52% reduction was found in HAIs post-implementation in the med-surg ICU, and 45% reduction in the postoperative telemetry unit. Statistically, post-intervention rates were much lower. Now, this is the visual of their HAIs, and if you look, you see the bars. This is not by site of infection. They looked at HAIs by organism. So the red part of the bar is MDROs, mainly gram-negative rods. Blue is C. difficile. And then the green is VRE, and the golden rod is MRSA. And so that's how they looked at it, and the rates are done per 1,000 patient days. And what you see is in med-surg ICU, pre-implementation is just 2009. Pre-implementation and post-telemetry, a lot more data, but you can see that there's a trend going down after CHG was implementing. Now, if you're a statistician, which I'm not, we know that when you have mixed or inconsistent implementation and post-implementation stages, that you got to do something special to the statistics. And so that's one of the things they had to do, a Poisson methodology to help make sure that they were able to give some equality to their results and their findings. So that's one thing that you need to be aware of, and actually to me is a limitation. Of course, their conclusion was standardized CHG daily with 4% CHG bathing program can be implemented to significantly reduce HAIs in ICUs and non-ICU settings. Of course, we need more than just these two units to tell us that, and there are a lot of other studies out there that do this, but I think we need some more, quite honestly. Limitations, big limitation I already talked to you about is the statistics, but then this is a big one, and we need to just recognize it. This was an observation study using unadjusted data, suggesting that a causal relationship between standardized CHG bathing and a reduction in HAI rates cannot be firmly established. But what they can conclude is that reduction in HAIs coincided with the adoption of CHG. Some important things they had in this paper in their discussion that I think are important for all of us. One is you got to standardize. Every study I look at on CHG bathing says you got to standardize the process, and they had that same opportunity. They also found that if they did not monitor compliance, what happened to compliance? It didn't go well. And so they had to establish a more rigorous way of making sure that their providers were doing the baths and doing them properly. The time studies showed that the standardized bathing process took 15 minutes per bath, which was much less than a lot of folks did. And you had some folks that did it in 5 minutes. And if they did it in 5 minutes, something was wrong, okay? They weren't doing a good job. The other thing is they talked about how they used the implementation in these two units to help make a decision at the leadership level to expand their program from these two units being universally implemented to other units within their organization. And they made that decision based on this information and looking at the financial opportunities that they were able to eliminate. So this next study, to me, I think is a very important one, and it's about decolonization in nursing homes. This is really, to me, an earmarked study that was published in the New England Journal in 2023. And we all know in this room that nursing home residents are at high risk for infection, right? We know that. And guess where most of our colonized patients that we don't know about come from when they're admitted to the hospital? The nursing home. And so sometimes they're admitted with infections, but sometimes they aren't, and they're just colonized with MDROs. So it's a patient environment that we need to look at and respect when we look at pathogen reduction. How many of you heard the term pathogen reduction and the fact that there's growing excitement about trying to look at ways to reduce our microbiome pathogens to prevent infection risk? Exactly, and that's part of what this is about right here. So what they did was a clustered, randomized clinical trial that evaluated the efficacy and the safety of universal decolonization compared to routine care bathing in the nursing home. Now, this was really a robust study. They did this in 28 nursing homes, and it occurred over an 18-month period, which included a baseline and intervention period. And what they did is they randomly assigned one of two. The nursing home either continued routine care bathing or they implemented universal decolonization. And the other thing that they did is they decolonized with CHG, but they also decolonized the nose, because the comments they made in this literature is, in this publication, is the nose is the major reservoir of what organism? Staph aureus. And so if you're going to universally decolonize, decolon the nose may be a good, and they use a protocol of povidone iodine. The outcome measures they used were also unique. They weren't HAI reductions. It was, the primary outcome was transfer to hospital due to infection. And then the secondary was transfer to the hospital for any reason. So as far as the results go, the efficacy included comparison of transfer due to infection, and they compared baseline versus the intervention. And the risk was lower in the decolonization group than in the routine care group, as you can see in this bar graph up here. At the top is the transfer to hospital due to infection, and you can see this lower rate. And then you see it in transfer for any reason. But I think all of us know by now that decolonization was associated with very few adverse effects. And when they had them during their training period when people were learning to actually implement an effective CHG bathing process. So, a couple things I want you to know about this study in a little detail. The baseline data. What they found was there were 10 transfers to hospitals per month per nursing home in these hospitals that they did this in, and 61% of them were due to infection. 61%. What we assumed. We sort of knew it, but now we know it better. Decolonization was their methodology because of this interest in pathogen reduction. And what they were able to identify is it does reduce risk of transfer due to infection. And what they estimated is that for an average 100-bed nursing home, they could prevent 1.9 infection-related hospitalizations per month. And then, of course, they also discussed the fact that it would reduce the risk of transfers and the prevalence of MDRO carriage in both the nursing home, right, and in the acute care hospital. They also discussed screening, and their thoughts on screening were, gosh, we're doing all this culture screening for MRSA and other bugs maybe like O. candida auris, if you're doing that. And it's labor intensive, it costs money, and then how long does it take us to get the results back? And what the author said is, why should we do something like that takes time when we can spend our money on doing a horizontal approach to reduce MRSA carriage, which they found to be 65% in this study. So, also theoretically, why use CHG? Because it reduces skin bacteria bioburden better than soap, and using povidone iodine. And there are other products available to reduce MRSA nasal decolonization, colonization in the nose. So were some limitations. There always are with a big, robust study like this. One of the most important ones, which is not a surprise that we saw, is that 3 of the 14 intervention sites didn't implement decolonization. Anybody want to guess why? It was turnover in their leadership. New leadership came in, and they looked at this research that was going on, and what did they say? We aren't going to do that anymore. And so they pulled out of the study. They also had several sites that had low adherence to povidone iodine decolonization. And the reason is that they required the RN to do that. And the question was in the discussion, could it have been better if the nursing assistants were permitted to do it? They also found, as we have found in everything that we've done where there's an issue with compliance, that we must audit and give feedback to improve adherence. If we let people do what they want to do, what happens? Not much. Not much. They also then wanted to tell us that decolonization training process may have affected the trial results, and we all know that's the case. When you teach somebody something new, they're going to do better for a while, or they may resist it for a while. It does have impact. So their conclusion was simply, among nursing home residents, universal decolonization with CHG for bathing and a regimen of nasal iodophor significantly reduced the risk of transfer to a hospital due to infection. Now, it would be wonderful if we could, I have a dream, and that dream is we could do this in every nursing home. What do you think are the chances of that happening? I think it could, but it would take some effort. What are the issues? Money, time, and turnover. So it'll be interesting to see where this goes, but this is quite interesting and I think important data for all of us. The last one was published in January 2025, so this is very recent. It was published in ICHE. And the background for this is we all know via the evidence that bathing ICU patients with CHG decreases HAIs. We know that. But what their question was is what is the optimal method of CHG bathing? As right now it remains undefined. And so they did a prospective crossover study that looked at daily bathing with 2% CHG wipes versus a 4% CHG solution. And if you look over here to the this side of your slide where I have my screen, what you see is the crossover. That this little preemptive 1 week before phase 1, which was 8 weeks, neuroscience did 2%, I think it's 2% CHG wipes, and the surgical ICU did 4%. They did it for 8 weeks. They had a break of that 1 week for re-education, and they switched. So both units experienced both types of bathing protocols, and then, of course, they collected all kinds of data related to that. One of the things they did is they cultured the arms, legs 3 times a week for 12 weeks to assess colonization reduction, which I think is cool. A lot of studies haven't done that. And the other thing they did is they used a test that assesses the CH level on the skin, which is also cool and new to many people. Of course, they also look at HAI impact and adverse reactions and skin tolerability, which all of these studies have looked at and find no issues. And these were their results. CHG bathing by either method is well tolerated and significantly decreases, there are significant decreases in microbial skin colonization. Now, the findings did find that the 2HG CHG wipes had a greater CHG concentrator and fewer organisms in the solution. However, in epidemiologists and IPs, I want you to hear me. You don't just look at the numbers of the colonization and the level. You got to look at the outcome. And in this situation, it didn't matter what if they used the wipe or the bathing solution. There was no statistically significant difference in HAIs between these two groups. Bottom line. They also did another thing that I think we should always do with studies when we're looking at differences of the way we care for patients, and that's cost. And so what they found was that, and it's direct cost of the product, for the 2% bathing wipe, it was $6.18 per patient. The bathing solution was less than $1 at 78%. So you could say that the liquid method of CHG bathing was maybe more cost effective. There, of course, were no reports of adverse events associated with CHG bathing during the study. So those 3 studies, I think, give us a little bit of idea about where things are going. And it's clear that there is a paradigm shift towards looking at a horizontal approach. And I don't know about you, I'm a seasoned IP of over 40 years. Yes, I'm old. And I really believe that the horizontal approach to infection prevention and control is the best way to go. It makes it simpler for everybody, et cetera, et cetera. But you've got to weigh what? The pros and cons. So let's go on to implementation. This is one of my favorite subjects, and I just want to share with you that halfway through my career as a young, passionate IP, I couldn't understand why I was doing all this great work. This is Connie. Connie said I was doing all this great work. And no one else did. I said it. And I would get approval, but then when we would implement it, nothing happened. And I thought, why in the heck is that happening? And I was at an APIC conference, and I went and heard Carla Alvarado talk about what? Human factors engineering. And what I learned very quickly, it's about people. It's about people. We got to focus on people more than we do. And we don't do it. Why don't we don't do it? Why don't we don't do it? We don't do it because it takes time, right? But I'm going to be honest with you. We've got to do it if we want to be successful. So a couple of things you need to know about change. This is the Kubler-Ross change curve. And I'll tell you, real change doesn't happen overnight. We go through emotions as individuals that start with shock, denial, frustration, then depression, and then we go back up and we say, okay, I guess we got to do this. So experimenting, decision-making, and then integration. I hear you out there, Lita. And so let me just say, it can even be with a good thing. You get a promotion. You're going to be the corporate director of IP somewhere. And you're shocked because why me? And then you think, oh my God, I can't do this. They didn't ask me to do this. And then we're frustrated because we don't know if we can do it. We go through this, is my point. And we have to accept that fact. We're all human beings and this happens, and it takes time to go through this process. So what does that mean with our implementation plans? What do we got to do to implementation plans to make them successful? We got to give people more time. And what do I mean by that? I would call there's a pre-implementation phase is what I'd like to call it. And what we got to do is let people know at least 6 to 8 weeks ahead of time. Guys, we made a decision to make a change because it'll help reduce our HAIs and whatever we want to say, help with penalty scores, all kinds of, fun stuff. Because they got to know the why. We're going to do it on this date, and we want to know how you feel about it. Let me know what you think. And I would actually do what I call sensing sessions. Going around, I'd take that suit off they made me wear and put on, scrubs and go out on the units and talk to those frontline staff to find out how they felt and get their opinion. And I did that early. What does that do to help them with their change process? It starts it. It starts it. You're communicating to them. So if you don't hear anything from me today, learn this in the fact that it takes time. Another thing that I learned, I got my change training from General Electric. They have an outstanding program. And this is a simple visual equation that they have about change. And it's this. It's quality or the process, whatever your standard is, times people equals results. Really simple. And what the studies show is that most people do a great job with writing the protocol, right? And getting it all done and maybe even getting approved, even though now getting anything approved is hard, especially if it costs money. But the people side of things is where we fail. We got to make sure that whatever we change is aligned with organizational priorities, number one. We got to make sure that people will be held accountable, which is another opportunity, and that the frontline staff understand the reasons why and the importance. We got to focus on people. And what have they done to education time in our healthcare organizations? It's gone the other way. And here I'm telling you this. So we've got to be creative. We've got to focus on people. If they don't do what we want them to do, what's going to happen to your results? Nothing, or it gets worse. So another article I want to direct you to, if you haven't seen it. It was published in APIC in 2023, and it was written by John Boyce, who is a leading expert in skin antisepsis. And, of course, CHG bathing was in this article. And one of the key things John talked about, he talked about how great it is at microbial, reducing pathogen pressure and stuff. But what I want you to hear him say is it's a great product, but we have got to really address certain barriers that studies that he looked at found these barriers to CHG bathing. Like we find barriers to everything, we just need to know these to help us. The first one, nurse stopped CHG bathing for an unknown reason. You know what the reason in my hospital was for nurses not bathing with CHG? Guess what it was? They didn't like it. It wasn't a traditional bath. It didn't feel like they were bathing their patient. It wasn't good old warm, sudsy soap and water with a basin. So what does that tell you? You got to deal with that culture. You got to deal with it. You got to do something to break it so that the change can occur. If you ignore it, you'll never get CHG bathing implemented in your organization. No assignment of responsibility. So I don't know about why an organization wouldn't assign. I guess they just said anyone in nursing. But if you don't assign who does it, is it going to get done? No. That's what some studies found. There is lack of bathing standardization, and the most frequently commented thing in all the articles I've read is this: standardize. Be very specific about your CHG bath. And also, make sure you educate your patients and families. A lot of patients complain that they didn't get a bath during their hospitalization. And when the root cause was looked at in some hospitals, what do they find? They didn't know that the bathing process with CHG was a bath because it wasn't like they thought a bath should be. You got to educate your patients and families to know what's going on. You got to make sure you educate. Now, we've already talked about inadequate education. This is a huge opportunity for healthcare and improving care and quality. And then lastly, you have variability of the application techniques of the agent. So, wish I could talk all day about this, but I'm going to summarize sustainable change in this one slide. There are several things you've got to do to sustain change. Number one, you got to do something that I call going slow to go fast. Go slow to go fast. What does that mean? You got to take the time to plan and be strategic in order to make sure you plan effectively. I've done it both ways. I've done it where I thought I was amazingly brilliant, but didn't plan well enough, and what happened? Nothing, all right? And then I did it this other way, and I thought, God, this is better. It's not perfect, but God, we got further along. So you got to create a shared need of the people. The people need to understand why they got to do it, and you've already heard me say that. Don't do anything unless it's aligned with organizational priorities. Don't go around somebody to do something because you know they won't like it, but you want to do it anyway because it isn't going to work. You got to plan and have a clear process. I see somebody smiling out there. They know what I'm talking about. You have to have a clear process and a plan. And you've got to shape a vision that identifies the full value to the patient and the organization. What do I mean by that? You don't always talk to them just about reducing HAIs. What else do you got to tell them about for the leadership to pay attention to you? How much does it cost? What is the impact on operations and finance of that organization? We're considered cost centers, but guess what? We can impact finance. And we need to make sure our leaders know that. We got to show our value. And then we've got to monitor and give feedback, and this is hard, but we got to figure it out. And it doesn't have to be the IP that does it, because one of the things I have down at the bottom is you got to work as a team, and we are better together. IPs can't do that alone. We have process improvement teams, but we got to make sure we work together. We can also use other resources like our industry partners to help us with education and training and things like that to help take some of the load off of the organization, whether it's you or the educators. So we got to use our resources. People. Know who are your influencers. Know who your decision makers are. Get some co-conspirators in your hospital that you can work with to help you get things done. You got to have them. You got to have them. And then you got to monitor and give that feedback. We've already talked about it enough. You will fail if you don't. And then you also have to make sure that the appropriate resources are available, including staffing. You know, sometimes they How many times have you seen a project be implemented and it can't be done because there's insufficient staffing to get it done? So, this is what I say about infection preventionists. I've known for many, many years, and I'm sure most of you do, all of you, we are change agents. That's what we do. We survey data, we identify opportunities for improvement, and then what do? We affect change to improve outcomes. And these are some of the characteristics that are actually part of leadership competencies that are expected by the certification that we as IPs must have. Do self-assessments. Look at yourself and say, what is it that I need to do better? I used to be shy, if you can believe it. And what did I have to learn how to do? I had to learn how to talk in front of people with whites all over me and not faint on the floor, right? We gotta assess ourselves to get better. So with that, I want to turn this over to Paulina, who's going to tell her story.
Thank you. Thank you, Connie, for that nice introduction, and Celeste as well. My name is Paulina Rodriguez. This is my disclaimer. So my healthcare system consists of 3 facilities, Hendrick Medical Center South with 165 staff beds, our North Campus, which is our biggest campus, 385, and our Brownwood Campus with 97 staff beds. The facility that we will focus on first will be the HMC South facility, where I have been the infection preventionist for the past 10 years. Prior to this, my background is in intensive care unit and in nursing education as well. So as you can see, our IP team is a very unified team. We often brainstorm on projects to further lower our HAIs based on concurrent and previous data and whatever trends we have going on. Our 3 consultants are also vetted IPs with many years of experience and also microbiology background. From the start of my IP role in 2015, my goal was to bring the IP to the bedside. To know what is going on in your facilities, you have to create that opportunity for a change and a connection with your clinical staff. This also includes the ancillary departments as well. I wanted our clinical staff to know that what they did or did not do at the bedside affected their patients and reporting from the infection prevention department. They also needed to know that they play a big role in the change towards better HAIs and patient care. I also found that they needed to know the why. And as someone who loves to teach, this is often why my own IP rounds take a little bit. As the problem statement reads, we were basically having bathing issues across the board. An increase in infection prevention in infection rates, especially CLABSI, a decrease in star quality ratings, also further assessment of current bathing practices revealed a lack of standardization and a lack of compliance. Further assessment also revealed patient complaints with the CHG wipe. They didn't consider it a bath and refused it altogether. Non-compliance with pre-op CHG bathing. Patients coming in for their surgeries were not doing their bathing prior to scheduled surgeries. And patients did not like the product. It was too sticky, and they didn't like how it made them feel. So in 2017, when I attended APIC, I came in with a purpose to find something that would possibly satisfy our customers, the patients, help our leaders, and increase our HCAHPS scores. Hibi Cleanse was the answer to everything we were facing at the time. Our aim was not simple, but complex. We needed to reduce infections and improve our patient outcomes. We also needed to increase our star quality rating. Our process improvement plan consisted of implementing an effective universal protocol. So this was a horizontal approach instead of selecting just certain units and certain patients. standardizing this care across a healthcare system, which eventually led to streamlining infection prevention efforts across all 3 HHS facilities. We also noticed that each facility had their own way of performing a basic bath or a CHG bath. Once we identified these gaps, we were able to work on standardizing the CHG bathing process. More on that in a later slide. So this is our timeline. In 2017, we started with one campus, HMC South, and we implemented a universal CHG bathing approach as an infection prevention strategy. The pilot was done in the ICU at HMC South with evaluations noting the ease of the 2-in-1 product. The current practice at the time was the 2% CHG impregnated wipe. With the buy-in of the C-suite, unit leaders, physicians, and clinical staff, a new practice change began to be accepted from a 2% CHG wipe to a 4% foam bath with cloth. The application of Hibi 4% CHG was easier than adopting a wipe product and can be applied at the same time a bath is given. Patients and their loved ones did not consider a CHG wipe down as bathing, and it gave them a further feeling of dependency. Also noted in the clinical evaluations was the safe nursing time and process and resources because of the ease of the Hibi 4% application. Of note to mention, when Hibi Universal Bathing System first came out, my rep at the time was Claire Dotson. She brought me a sample, and we were actually the first US hospital to implement the hub system. Our staff, our patients, their loved ones further loved this application because they could hear the water running, thus indicating a real bath or treatment. So this is an article that was published in Infection Control Today, June 2018, and it's noting our success of decreasing our CLABSI by 67.8% after 8 months of Hibi implementation. We also increased our star rating and HCAP scores. We decreased complaints from patients not receiving a bath while hospitalized at our facility. So let's talk about results. So we all know what happened in 2020, 2021, and the repercussions to HAIs, and for us, this was continued to 2022, coupled with a new transition in corporations and change in processes from what we had been the norm for many years. We definitely saw a confusion on products used from one facility to the other. A simple patient bath was confusing because of the change in processes as well. So in 2022, we reached out to our Manleka vendor support team for a much needed re-education and back to basics of CHG Hibi bathing. In 2023, we continued to re-emphasize the horizontal approach of CHG bathing at the South Campus, which had us back to decreasing our HAI trends. From 2023 to 2024 and early 2025, we had no CLABSI events at HMC South. From 2024 to 2025, present time, we have no MRSA events as well. Shared success. Thank you. So in the fall of 2023, we started to set up the conversation on having the North Hospital, which is the bigger hospital, do a pilot for the Nissen reportable units to decrease a reportable HAIs. Leadership and physicians' buy-in was a must to succeed in the change that the IP department wanted to bring about to positively impact and decrease HAIs at our bigger hospital, especially because we were not meeting our 5 quality domains. So the South Campus really wanted to share their wins with the rest of the HHS system. The decision was made to roll out the horizontal approach of CHG bathing with Hibiclens because of its cost effectiveness, but also because of the decrease in HAI stats that the South Campus had previously and concurrently reported. So in July 2024, we rolled it out successfully to all 3 HHS campuses. As IPs, we are the change agents who own the data. And so we use this NIST data to get leadership support. So fast forward to February 2024. There was not a standardized approach to CHG bathing with the goal to standardize all 3 facilities by adopting the best practices at each one. An assessment was done and revealed varied and inconsistent CHG bathing practices across the 3 hospitals. One hospital, for instance, was using basins. They were one and done, but were they really? Another hospital was using a different wipe that had its own ingredients along with the Hibiclens. And so, yes, so there wasn't a standardized approach. The pilot protocol consisted of 4% CHG foam cleanser, selected units, comprehensive education demonstrations, and product rollout. The IP team chose units at HMC North to be part of the soft launch. In February 2024, a soft launch pilot was initiated. This encompassed 4 Nissen reportable units at North. There was not, again, a standardized approach to CHG bathing, so implementation consisted of a comprehensive educational program for clinicians before product rollout and ongoing follow-ups after the rollouts. At this point, collaboration with our Hibiclens rep was crucial for a successful project. HMC North had implementation challenges from the beginning, mostly around stabilizing the daily usage levels. The North Campus daily census can hover between 300 to 400 daily patients, so initial demand exceeded the daily usage. And so we learned from these challenges and were better prepared for the universal approach. It took only 45 days to launch this process universally. We had positive feedback from the leadership, and the leadership at all hospitals wanted this universal approach sooner than later. The adjustment and revisions made after and during the first pilot helped to solidify the second phase of the pilot. It took 2 months to stabilize all the units with their adequate PAR levels. Our Hibiclens rep assisted us with the cost analysis, presentation to materials management, and when you can speak their number language, along with cost savings in each HAI, it was a resounding acceptance and welcomed change, not only for the facilities, but for the overall patient care. Comprehensive education extended to specialty areas as well, like our orthopedic joint units, our pre-admission testing, and even the cath lab as well. So we also implemented a pre- and inpatient and post-Hibiclens process of bathing for our surgical patients. The Hibiclens bottle is provided to the patient at pre-op admission and also sent home with the patient upon discharge. The continued vendor support and follow-up is critical and is widely attributed to our success story, the Hibiclens universal bathing process. So results on infection rates. So for the CLABSI graph, as you can see, our North Campus needed to add another layer of infection prevention, and CHG Hibiclens was added as a horizontal approach. And once it was implemented, we started to show that decline. The South Campus had 0 CLABSI last year and the year previous to that, so 23-24, both internal reporting and NISN reporting. And this is something that I've always done, is I've always tracked my BSIs as well. I think it tells you the story of how to prevent your CLABSIs as well. So for MRSA, South Campus last year, again, 0 lab ID. 3 things that are very common in our West Texas area. It is C. diff, MRSA, and Hep C. Also note that smaller facilities with a lower denominator, such as South and Brownwood, anytime you have an infection, it quickly takes you above that SIR of 1, right? So using multiple levels of infection prevention is crucial for these small facilities in decreasing their HAI count. So now let's talk about CHG bathing audits. So the chart audits were introduced to ensure compliance in all campuses, and it was added as a performance improvement goal after CHG implementation. The PI CHG bathing audits began in July of 2023, and the Hibi cleanse chart audits, either by the IP or the unit leaders, was something that was emphasized always at South. So we had been using the product a whole lot longer. It is easy to check my ICU, and this is something that I like about Hibi cleanse, is that when I go through my ICU unit, it's easy to spot that bottle. And so if the bottle is not in the room, I'm having a conversation with that ICU nurse. And so usually they're like, we just got the patient, Paulina. I can speak to it. And so anyway, they don't want a bad mark. So yeah. So we also started tracking the patient refusal rates for possible trends in units or clinical staff members, okay? So we usually go over these CHG stats with our leaders, our managers, on a monthly basis. They post it on their units so their staff can see. And so this is a way of just keeping that communication going. So our biggest wins. Staff is hungry for better infection prevention knowledge to improve patient safety. And outcomes, they want to do what is best for the patient. By standardizing the CHG bathing protocols, all 3 campuses, we improved infection prevention efforts. We reduced HAIs across the board, improved quality ratings, and resolved product issues. This slide shows our quality goals for 2024 fiscal year for the month of October. After implementing Hibi cleanse in a horizontal approach to all HHS facilities, this is what happened. We were able to meet our quality goals with 4 out of 5 and 5 out of 5. And so this had actually never happened at HHS. And so this was a big goal success for the quality department, especially infection prevention. Transferability, so additional benefits. Our success inspired another facility within our network of hospitals to adopt similar CHG protocols. Continuous evaluation ensures sustained compliance and improvement with chart auditing and unit reporting. The vendor education and support speaking to the right clinical staff at the bedside, which for me, it's our PCTs. They're the ones that are giving the baths, except for ICU, it's the ICU nurses that give the baths. So this helps sustain these achievements. Optimizing patient care, our process can be easily disseminated to others because it's an easy step-by-step process. So I would like to take a minute to focus on the CHG targeted bath procedure. So this is an approach that came about because of the need to increase our scores for our PI project, and so in auditing CHG documentation. So it is also another way to deliver the Hibi cleanse bath or treatment and still keeping the patient's needs in mind. This approach is for patients refusing a full Hibi cleanse shower or Hibi cleanse bed bath. So just as it reads, we target the hands, the device area, the surgical area, and the drain area perimeter. And so 6 inches out is what we do. Might as well take a whole bath, right? As IPs and being the change agents that we are, we work together as a team to come up with ideas such as this. So networking and sharing our wins with others is something that I love about our profession. Why reinvent the wheel? Instead, share your wins with other IPs and inspire them to have their own wins too. When we share our IP knowledge with others, everyone wins, and everyone becomes an advocate for infection prevention as well. In looking at ways to improve our compliance with our universal bathing, we focused on the following areas, which is documentation. We streamlined the flow sheet to have a smaller number of choices. The capsule is a vital sign machine that integrates into the electronic medical record. And so the PCT, who's the one giving the bath, they're able to document at the bedside real time and capture that CHG documentation. Quality CHG audits. So increasing these audits to capture longer length of stay patients for more data analysis. So our data analyst looks for those patients with longer stays, and that way they can look at more CHG documentation, okay? As you can see by our CHG compliance for all 3 facilities, our data just keeps getting better and better. I also started what I call IP chats with PCTs. And so just as it reads, it is a way for, it's a way that facilitates the IP to have a sit-down conversation with our PCTs and gather their feedback on products, on concerns, and thoughts on how to better prevent infections for our facilities. And so again, emphasizing what you do or don't do at the bedside affects the patient and the IP reporting for HAIs. So in summary, infection prevention is everyone's business, and it takes a team approach. And the IPs play a key part of this performance improvement and change. We as IPs are the catalyst to making that change in our organizations and people we work with. Having leadership support and buy-in is also an essential part of this change. Vendor support beyond just selling a product serves as a huge resource. And so we are very lucky to have this with our Maleka representative, Chrissy Barker. In fact, she has us very spoiled, if you ask my teammates, because of the HHS implementation, the repeated education, and the ongoing support. It's wonderful. In fact, this has our facilities thriving in this success story. Remember to celebrate and share your successes within your network of IPs, but most importantly, with your own first-line clinical staff. So this is one of my favorite quotes from Mother Teresa. World, but I can cast a stone across the water to create many ripples. Think about it. As IPs, we need to be able to be at the ready and ahead of HAIs for the safety of our patients and our staff. It is up to us to create that change and start the ripple effect for better HAI prevention at our facilities. Thank you. And now Connie will give closing remarks.
Thank you, Paulina. So I want to talk about Paulina for a minute. What do you think? She affected change. She was and is an influencer. What is an influencer? It's a person with the capacity and power to ignite a movement within the circles of influence and create a community of creators. Is that not exactly what she did? It is. So if you've never read the book, The Influencer, read it. It helped me a lot, and I see all the characteristics in Paulina. My quote relating to influence is this: you never influence the world by being just like it. You got to be different. You got to be unique. Think outside the box. Think big. The worst thing you do is fail. It's okay to do that every once in a while. But if you don't take risks, you don't ever know what you would do if something happened and you took that risk in it and you did it. You did it. And as Paulina said, they celebrated success of this organization. And I think it's really important for us to do this. Not only celebrate our organizations when they do well and those frontline staff like Paulina did, we got to also remember to celebrate who? Ourselves. We need to also make sure we recognize the work of our peers and of our own individual self. And that's really important to do. So do that, self-care. And my favorite quote, I look at this every day when I wake up in the morning because I think it's so important. We can change the world and make it a better place. It's in our hands to make a difference. And that's what everyone in this room can do. So we have some key takeaways. Number one, evidence suggests that skin decolonization via CHG bathing is effective in infection, as far as an infection reduction strategy goes. It's also an effective strategy when used as a standardized approach. That's very key in everything that I've read and the experience you heard from Paulina today. We're starting to see an emergence of people using universal decolonization. A lot of it's not published. Some of it is. But what I would say is this makes me happy as a horizontal approach person. I think it makes sense. And I think it's something we need to think about, specifically in the area of pathogen reduction, which seems to be a very important component that we'll be learning more about in the coming years. We also talked briefly about successful implementation of change and what it requires. It requires alignment with operational priorities, a standardized process and time, a focus on people, communication about why, how, and when, monitoring for sustainability, and making sure you have the needed resources. And of course, Hendrick Health's success story is I think, an amazing example of what infection preventionists can do. She is an influencer and a change agent, and so are all of you.